Hello and welcome to our third Health on the Plains coffee hour. Thank you all for being here today and continuing on till the last Wednesday of the month in October. I'll spend this hour with you all with my cup of coffee and a great leader in the world of rural communities, rural health. And now we know this time doesn't work for everyone. We're glad it works for you and glad you're here. But it is going to be recorded so that if folks aren't able to join, they're able to learn from our great guest as well. My name is Wyatt Beckman. I'm a senior analyst and portfolio strategist at the Kansas Health Institute. And I'm really thrilled to host this series. The Kansas Health Institute, for those that are not familiar, is a nonprofit, nonpartisan educational organization based in Topeka. We believe that evidence-based information, objective analysis, and civil dialogue can inform and support effective policies, programs, and interventions for healthier communities. Now, this series is built on the idea that nuanced conversations like the one we'll have today with thoughtful people can help us better understand the many factors that shape rural health and well-being. With that better understanding, we can all work to envision and implement more effective strategies with and in our rural communities. Now, oftentimes, I find the best conversations are guided by a good question. And today, that question is, what are the opportunities for positive rural healthcare transformation within a rapidly changing policy environment? And I'm super excited to have our guest today help us think through that question. Here to talk about it is our guest, Brock Slabach. Brock is the Chief Operations Officer at the National Rural Health Association, which he joined in 2008. He was a rural hospital administrator for more than 21 years and has served on the board of the National Rural Health Association and the Regional Policy Board at the American Hospital Association. Brock knows lots of things, but he specializes in rural health system development that encompasses population health and the varied payment programs moving rural providers into value-based purchasing models. He serves on the Board of Commissioners for the ACHC, the Accreditation Commission for Healthcare, and the Board of Directors for the Pennsylvania Rural Health Redesign Center organization. Brock's been recognized for several awards. Back in 2015, he was the recipient of the Calico Quality Leadership Award of the National Rural Health Resource Center. He also received the American Society of Healthcare Pharmacists Board of Directors Award in 2018. Most recently, he won the NRHA's President's Award in 2023. Brock earned a Master of Public Health degree in Health Administration from the University of Oklahoma and is a fellow of the American College of Healthcare Executives. Now, Brock, thank you so much for being here. We're really excited to have you join us.
Thank you, Wyatt. It's a pleasure to be here, and I have such a large amount of respect for KHI and the work that you all do. So thank you for your part in keeping us informed on important health issues.
Of course, we're happy to do that, and happy to have this space to talk today and learn together. And as Lindsay shared in chat, if you wanna share thoughts or questions for Brock as we get into this discussion, please use the chat and the Q&A feature. Brock, we frame this as our Health on the Plains coffee hour series, and I already showed my cup of coffee, and I know you've traveled all over the country and likely had more hospital coffee than just about anyone. So how do you prefer your coffee? What's the best hospital coffee that you've had?
Well, thank you, Wyatt. Yes, I have my cup of coffee here with me as well, and I like it black. For some reason, my mom thought it important that we couldn't drink it until we could do it without milk and sugar. So I guess that was a good lesson for us in terms of patience. But I drink community coffee. I lived in Mississippi for 20 years, and it's the regional coffee for that area. I will tell you that I made the mistake one time of going to our group purchasing coffee that was Duvet Egberts. And I had a mutiny on the Bounty with my staff because they were terribly upset that I took their coffee away from them. Needless to say, that lasted about a month. We went back to community coffee, and I still drink it now. So this is what's in my cup at the moment.
Well, your Holly is agreeing with you, another fan there. But a funny story about the importance of coffee and coffee at a hospital that everyone likes. And I know you grew up in rural Kansas, and you mentioned being down in Mississippi. You spent more than 2 decades serving as a rural hospital administrator before stepping into your role that we'll talk more about now. But much of that time was spent in Centerville. So tell me more about that time and some of the lessons you learned beyond, the importance of a good cup of coffee.
Well, that gets us started and puts us in a better mood, I think. And then, having said that, yeah, I mean, serendipity has been kind of a key word in my life. I didn't expect to ever live in Mississippi. I left graduate school at the University of Oklahoma, as you mentioned, and went to work in Ohio. I spent some time in Pennsylvania as an assistant, as a interim administrator, and then spent some time in West Virginia. And they asked me to go and start up a new account in Mississippi. And I drove up to this hospital. It was a typical Hilburton 1948 facility with the rolling windows. I don't know if you remember hospitals that had those windows that looked like roll-ups, and you could open them, crack them open. And I thought, oh my gosh, how long am I going to stay here? And I had no idea it'd be 20 years. But what I can tell you about Centerville is it's really a well-kept secret. They had a great medical staff, a great board. The community supported the hospital. It served 2 counties. For a rural hospital administrator, you can't ask for anything better than that. And so I stayed until I took my job here at National Rural Health Association. And I can tell you, it was a real challenge. I mean, it was really distressing to leave that community. It was a really tough time. But anyway, times move on, and I'm glad to be where I'm at now and to be here with you today.
And I imagine when you having had that 20 years of experience doing that work, when you step into meetings, when you're on the road, talking with current hospital administrators and leaders, you can step into those conversations with some real lived experience and a sense that, I was in your shoes. Is that helpful when you go out and try to support healthcare leaders now?
Yeah, Wyatt, it's a great point. There's not a day that goes by that I'm not thinking of a relative experience that I had or some instructional lesson that I learned, probably the hard way, in terms of how to address a problem. And if I can help people to avoid making the same mistakes that I did, I'm always happy to do that. And I think, in this environment especially, it's pretty challenging. It's always been challenging for rural hospitals and their clinics, but I think that, yeah, no, I draw upon that experience and I cherish it really because it is what brings me here today, and I think that's all some of those experiences that make us who we are.
Yeah, you mentioned some of the challenges, and I've heard you remark that rural healthcare is not a smaller, shrunken down version of urban healthcare. And it's still healthcare, but there are some unique features. And I'm curious, what do you see as the biggest challenges facing rural healthcare, and have those changed since the time you were a CEO?
Yeah, it's interesting. Great question. I look back over time, and we do have intractable problems that have always been difficult for us. Reimbursement has never been equal to our urban counterparts. So you go all the way back to Medicare and Medicaid in 1965, the development of the federally qualified health centers the next year in 67, 66. And you can see then this disparate treatment between rural hospitals and urban hospitals. So the assumption is that, like you said, one size fits all. Rural hospitals are just miniature versions of the Via Christi's in Wichita or the bigger hospitals in our urban centers. And then nothing could be further from the truth. So we had, and I'll just give you a policy example of what happens when you don't test or make demonstration of a policy impact ahead of time. And that's the development of the prospective payment system back in 1983. It transformed all hospital reimbursement from cost-based to a prospective system. And that generated what I consider to be our first closure crisis, which was from about 83 to about 92. Over 400 hospitals closed as a result of that one policy development. And then when they talked to the researchers at Harvard and Johns Hopkins, two really well-known rural universities, I say that facetiously, the generators of the prospective payment system said, well, we never tested, nor did we demonstrate any effect on small volume rural providers. So it's like, you can't blame us. CMS was the one, the Centers for Medicare and Medicaid Services in the United States government. They are the ones that implemented this policy. And so I guess my point is that what we've been doing at our association since 1978, when we got started, in the National Rural Health Association, is we've been pointing out these payment disparities and trying to focus attention so that we can eliminate those. So reimbursement's always been a problem. The other area is workforce, and I could talk about that for the rest of the hour, but those two things, I think, together over time have been something that we've always dealt with.
And has workforce been challenging in similar ways or different ways since when you were leading a hospital and thinking about hiring and retaining workforce?
It's gotten harder. I'll say that definitely since the pandemic, and I think the pandemic has put a focus on a lot of the workforce issues that we're dealing with now. But I think, again, going back in time in terms of history, we look at, there's always this saying that I used to hear it growing up, that eggs are cheaper in the country. And I think that there's this kind of myth that our urban friends think that because we're in rural areas, we're smaller, that things are cheaper. And it's certainly not the case when you're competing for workforce in a national environment. In other words, you can't really pay nurses or doctors that much different than what they get in the cities, because it's harder to attract them to come to our rural places. And so we really have to be sensitive to that.
Yeah, that's a I you know side note, I find eggs are cheapest when your family grows them and they give them to you for free, which I happen to have from my family that lives in small town. But that is, I could see how that plays in, the idea that things are smaller, there's fewer options, and it's simpler, and simpler maybe means cheaper, but the competition scale is not that. You're competing at that national, regional level. So thanks for some sort of level grounding in some of these challenges, maybe some ways that they have shifted. We've seen some policy changes. You mentioned some that have had some impacts, and the importance. I think you really highlighted the importance of critically thinking it through in terms of what does this look like in rural places, and really testing that policy change. And I'm can't help but think about a recent policy change that I think we'll spend quite a bit of time talking about. And our guiding question is around rural healthcare transformation. And I'm sure most, if not all, people on the call have heard about some really big policy shifts. And I want to talk about HR1, or the One Big Beautiful Bill Act. And among lots of things in that law, I want to specifically talk about the $50 billion fund called the Rural Health Transformation Program. That program was put in an attempt to offset some losses that rural health providers are expected to experience associated with some of the other pieces in the legislation. As we'll discuss, there's lots of details still to be figured out when it comes to this program, but can you summarize it for us and give people a sense of what is this program, what's it trying to accomplish, and how is this funding set to be sent out?
Yeah, Wyatt, this is a big question, and it was hotly debated during the lead up to the passage of the One Big Beautiful Bill Act. I'll refer to it here as OB3 just because I get a little tongue-tied when I start saying all those B words together. So OB3 was passed and signed into law on July 4th of this year, and it really had some sweeping impacts. Obviously, some of the advantages to us as citizens is that it kept some of the tax cuts in place. It significantly reduced other taxes that had not been that were set high, and so that side of it maybe is probably a good thing. The problem is that they were looking for pay-fors to pass this bill. In other words, they needed to have some reductions in spending in order to reduce the expected deficit. So the bill contemplated a little bit over 1 trillion, that's with a T, $1 trillion in reductions, particularly isolated to the Medicaid program. So Medicaid is Title 19 in the Social Security Act, and it is a program that was designed in 1965 to help protect the poorer folks so that they don't become impoverished due to high medical expenses. And so this $1 trillion is going to come out of that bill, come out of payments that are currently being expected to over the next 10 years for providers, hospitals, clinics, nursing homes. I mean, anybody that's receiving Medicaid payments will be impacted by this in some way. And so that $1 trillion, a lot of money by anybody's estimation, is seen to disproportionately impact rural facilities because we depend upon government payments, both Medicare and Medicaid together, than our urban counterparts. And so we're looking at this as being a disproportionate impact. So the reason why that's important is because when the Senate considered the OB3 bill, there was a lot of pushback from particularly farm state Republicans to the Medicaid cuts. And I don't think they were looking for solutions. How do we get around this problem of what we're going to do to help rural facilities manage these deep cuts to Medicaid? And they came up with this Rural Health Transformation Program. It was an idea that was championed by Senator Susan Collins from Maine. There were a couple of other small state Republicans that pushed this through, and it started out at 25 billion. Then it ended up at 50. Just a side note, Senator Josh Hawley from our neighbor next door in Missouri, he has a bill in place now to raise it to 100 billion. So it looks looking like that. I don't think that probably has much of a chance of passing. But I think my point is that this bill, the OB3, would not have passed. In other words, it could have tanked in the Senate had it not been for this rural health transformation inclusion. So it's 50 billion. It's a 5-year program, meaning that they'll start sending money to states on January 1st of 2026. Then it'll last for 5 years. And when that 5 years is up, then the program ends. And so there's no provision for it to be extended. We don't have any current law that would indicate that it's going to go beyond that 5 years. And the funding mechanisms I can go into if you'd like, but that's really the overview, kind of the lead up to why that was even a thing included in OB3 and how important it is to mitigate the $137 billion in cuts directly from rural providers nationwide as a result of OB3.
Thanks for that really great background and setup. And I'll just flag for folks, you all have put together a nice summary at NRHA, and Lindsay shared that in chat. So invite people to grab that and save that, and an invitation to, as we get further and further, any point, feel free to add into chat or add
Yeah.
questions in the Q&A that you'd like Brock to wrestle with. I do want to get a little bit into some of the particulars of this funding and this program and how the funding will be distributed, because I think that's, as we think about, your example previously, some of the details of these policies matter and how the funding could be distributed and who it reaches and for what purposes. So uh, talk a little bit about the basic setup of distribution. How will that 50 billion be divided among the states?
Great question. It is going to be so there's two tranches of money envisioned in this bill. I'll call them tiers. So tier one is I call it the equality provision. It is that every state, all 50 states, will receive a share of one half of the money, or $25 billion. So that's an equal distribution, an easy calculation. Kansas will get $100 million for 5 years per year. So that's in track one, or tier one of funding. The second tier is a proportional amount of funding depending upon rurality. Essentially, how many rural facilities in the state as compared to the total number of facilities in the country. There are some other factors that can be considered. And then the last provision in the law states that the CMS administrator can implement other factors as they see appropriate. So we don't know exactly. We'll hear soon. I've just learned today that they're expecting the application for this fund to be delivered in mid-September. So we're looking about maybe around the 15th, if you look at mid being halfway. And so we'll know more about the funding streams once the guidance is released. So I'm presuming that a state like Kansas, with a very large rural space and we have over 80 critical access hospitals in Kansas. So I'm expecting that we could get another equal share at least of that second tranche of money, which could be a second bucket of 100 million. So you could be looking in Kansas at a funding stream of possibly $200 million per year um, going forward for 5 years.
And Holly had a clarifying question
Mhm.
in chat, and I think you just answered it. But was that 100 billion or 100 million? 100 million for Kansas for that equal portion, and then
Correct.
there is some unknown as to exactly how that proportional calculation will be determined. But then there's a whole another set of potential variability in terms of how states actually think about using this funding. And from what I've seen and what I've heard and uh, read, it seems like there may be a variety of different approaches taken in this short timeline to determine how they want to use this funding, what's the best way to achieve this rural health transformation. How are you all thinking about the potential variation we could see from state to state? How Kansas could take a very different approach than just across the border in Missouri?
Well, Wyatt, you've touched on one of the good parts of the bill and perhaps the bad part to the bill. I think there's a lot of opportunity here. They've decided to let experimentation be the rule in maybe 50 different laboratories, I'll call it. So 50 different states will take a different approach to how they determine the use of the money. So the way that um, CMS Administrator Mehmet Oz put this forward in a meeting that we had with him back in July, he expects that the governors of each state will be responsible, will be the person that CMS will confer with on the application process. The governor is likely in each state to delegate to one of the agencies within state government, or they can pick maybe a health advisor, or in Mississippi, they put out an RFP for a grant writer to assist the state, the Department of Health and the Division of Medicaid to write the grant that will be due. So if the grant comes out, just a couple of timeline. If the grant comes out on September 15th, we've been told from CMS that there will be a 6-week application window. So we could be looking at the end of October as the due date for this funding opportunity. I can't underscore enough how difficult it could be to spend maybe $200 million. I know people would like to have that problem, but spending that kind of money with an application period of 6 weeks is pretty daunting. And so back to your question, the governor will delegate. The state will come up with a funding mechanism. Hopefully, the state will implement some stakeholder input to the process. And I'm sorry, I'm not too up to date on the Kansas implementation process, but I do know that states are having meetings around what could be the possibility for the use of this money. And I think there's a lot of stakeholders that are looking to get ideas that they can put forward to the governor to include in this funding opportunity.
And as part of that plan, there has to be some in a fairly short timeline, as you mentioned, outline of how the state will approach using this funding. And there's some specific areas that are mentioned that this funding can be used for. And I'm seeing the question in chat from Ashton. Could this be used to hire staffing to help with applications for programs such as the presumptive eligibility program?
So that's a great question. I would say that I'll answer it this way. If you look there's a list in the law, and I think our sheet that's attached to this webinar now that we have provided you illustrates the potential uses for the funding. And the law states the law is pretty exhaustive in terms of what it expects you can use the funds for. So one of the line items is for uses of funding is direct payment to providers. Director Oz said in a meeting that he did not anticipate CMS approving applications that exclusively relied on or the abundance of the money going just to providers. So they're expecting this to be used as a transformation of rural health, not just subsidizing current operations. Now, that's not to say you can't do that. It's just that I think you can't use all of the money for direct payment to providers. So what I've been hearing, and I think it's some great ideas, is that you may not be able to support directly a provider, but maybe you could offset some of the current expenses that are being made by hospitals in terms of their operations. So one of the line items is electronic health records, modernizing your information systems to be able to better care for patients in your community. So if you're going to spend $1 million in the next 3 years for an upgrade to your EHR, electronic health record, maybe this grant program could pay for that, and that would ease, your losses from these expected Medicaid cuts that might come down the line in a few years. So that's just an example, one big example of what could be the use of the money.
Yeah, thanks for digging into that question. So you mentioned the word of the hour, transformation. This is framed as a transformation program, and I think we've talked about it. I think there is an acknowledgement that there are some ongoing and persistent challenges in rural health care, and that's part of why this fund was added, offset some of the potential challenges introduced other parts. And you've touched on some of those challenges that you've seen in your time at NRHA and as a hospital administrator. And you've also used the word opportunity. This funding certainly presents an opportunity for transformation. So how do you think this funding really can be truly transformational? And importantly, what what could stand in the way of it being the sort of transformation that we may all hope for from this great opportunity?
That's a really loaded question. I have to say, I'm not going to lie that when the bill passed and they called it the Rural Health Transformation Program, the word transformation is used so often it just becomes kind of a cliche. It seems almost because we've been talking about transformation in rural health for years now, and it's really difficult to think about transformation in the context of the realities of the current operations of many of our rural facilities. I mean, when you're having a difficult time making your next payroll, the food delivery has to be paid for with a check at the time they bring it because you've lost your credit. And this is the reality of a lot of hospitals nationwide. The thought of transforming yourself into something brand new is the last thing you're thinking about. And I think we need to be looking at how we can develop the infrastructure of our rural facilities, the leadership infrastructure, to be able to manage some of the change that facilities are looking and hoping they can do at some point. So I would look at an investment in leadership capacity, perhaps for use of some of this money, and how facilities through strategic planning, through maybe some technical assistance, on a strategic financial operational assessment. So the monies can be used for that. So states could look at an entity that could manage technical assistance for leadership and for assistance in current operations to help them fine tune and make them better. So I would caution transformation until you've gotten the basics out of the way. But when you talk about transformation, what does that mean? And I think that I spend a lot of my time in uh, value-based care discussions. How do we move from I have a colleague who talks about we have a foot we're on a shaky bridge right now. We're leaving the old system and we're moving to a new system, and unfortunately, that bridge shakes pretty hard when you're trying to make that crossing. And we need to find a way to be more supportive of rural hospitals and clinics to be able to make that transition. So what does that mean? It means possibly using some of the money if you're in a rural hospital network. Maybe a funding stream for some of the money in the state could go to that network to help develop some of that infrastructure in terms of uh, innovation. So our friends up in North Dakota, for example, just started about 3 years ago, the Rough Riders Network. It's a 28 hospital member network, and they got a $3 or $4 million appropriation from the state to help them fund the infrastructure needed to get that network off the ground. And so with that money, they've been able to move to what we call a single signature authority contracting with managed care companies. So 28 hospitals are getting together to have one person negotiate for all 28 facilities managed care contracts, which is a very difficult job for any rural hospital. And I could go into that if that's way too difficult and way too much to talk about here. But that's a difficult process, and that could be something. That's an example of what infrastructure could be used for to develop the techniques and the capacities for our facilities to be able to compete in this modern environment.
Great image of this shaky bridge. So, and I think about, we hope this funding can be transformational, but I can imagine this experience of it's hard to look really far in the future and be really creative when you're really just holding on for dear life. And maybe that's the situation that unfortunately a lot of our rural healthcare providers and professionals feel they're stuck in. Another piece that has come up that I'm curious to hear your thoughts on how this could play into how we think about transformation is this pretty quick timeline and rapid development process. So mid-September, 6-week application period window, and then January 1st, ready to go here, get going. That's pretty quick. How do you think that presents an opportunity or a challenge for being creative and innovative and transformational, and how states or partners think about using this funding?
That is the dilemma, isn't it? I mean, to stand up something pretty sophisticated with a very limited amount of time to get all the stakeholders together that would need to be included to be able to implement something effective. So what I've been thinking through is how a state could maybe fund a I'll call it a think tank or an organization that would use these funds to implement a program of services that would be defined as part of the development of the project. So you could have an agency that would take, say, $10 million a year for 5 years and develop technical assistance for rural hospitals, present assistance to networks that need money, kind of like a granting agency. And I'm not sure how CMS would approach that in terms of the application, but there's so many details that have to be ironed out in the next 60 days or so that it would be really hard to get all of those stakeholders together and agree on the strategy immediately. I've been trying to think through this, and I think that would be probably the best effort to perhaps get the money, be able to set up the plan for how the money will be spent in terms of programming, but then leave the programming up to the agency that hosts the funds to be able to develop the pathway to make that happen.
There's a couple questions. One in chat I'll go to first.
Mhm.
And you mentioned earlier about the role that the governor's office has in creating the plan, or sort of responsibility. But Liz asks, who do you think should be in charge of creating the plan? And they specifically focus on Kansas. Any sense on, and maybe you can broaden that question, who all should be at the table or could be beneficial to have it at the table in creating these plans?
Well, frankly, I think the governor's office makes a lot of sense to start, at least, because I think they're attuned to hopefully the political realities in their states and have the sense of how a structure could be used or set up to spend this kind of money. Then they will need help. So I mean, it in some states, like in Pennsylvania, I was on the call this morning with Pennsylvania hospitals. Their Department of Human Services, essentially the Medicaid agency, is going to be tasked uh, with writing the grant application, and they're seeking input from stakeholders, and they're looking at all of the things that we've just talked about. Mississippi, it's the Department of Health along with the Medicaid division, so they're separating the responsibility between two agencies in some form and fashion. So I think it just depends on the state. It depends on, what some of the structures or how they're formed. Then I think, yes, stakeholder input is going to be absolutely essential. So I know my friends at the Kansas Hospital Association, I'm sure, they're working very hard at trying to navigate some of the um, structures that will be in place once CMS guidance comes out September 15th or thereabouts, and trying to make sure that input is provided to the governor in terms of needs. I will quickly say that one of the instructions or educational pieces that I provide to hospitals in a PowerPoint presentation I have is I think it's useful to go, if you're a clinic or a hospital, to isolate or to identify all of the cuts that are anticipated in the Medicaid program vis-a-vis the OB3, the One Big Beautiful Bill Act, and to have that number in mind. Let's say it's $1 million over the next 10 years. I'm just using that as an example. I think that it would be helpful and informative to the grant writers to know how much hospitals stand to lose over the next 10 years in terms of the input of or the impact of this OB3. And And I think that that is a critical piece of information because because if you look at the Senate originators of this bill, uh, they were very direct in their conversation. Congressional intent, I think, was to basically mitigate the losses that hospitals were going to incur over this in this program over the next 10 years. So that I think is something that would be useful detail, useful data to be able to share with the grant writers.
Really getting into the particulars of thinking this all the way through. You mentioned stakeholders as you know the role of hearing from different groups, and there's another question
Mhm.
mentions another group. This comes from Holly and the Q&A. And will there be or is there a way that faith-based groups can partner with our rural healthcare facilities to aid them in their services in relation to some of this work?
Yeah, that's a great question. Certainly, faith-based organizations are, I think, are essential in terms of programming um, of any program in a rural community. I'm looking up here. So there are so eligible facilities. Let's talk about that a second. So the law, and I didn't mention this earlier, the law does have a list of eligible facilities. It should be on the tip sheet that you put on the attached to this Zoom call today. The eligible facilities are listed there. And obviously hospitals, it's the Federal Office of Rural Health Policy definition of hospitals, meaning they have to be in a rural area, or if you're in a metropolitan statistical area, like say you're in the Wichita area, if you are in a rural census tract of an MSA, then you're eligible. Federally qualified health centers are eligible, and so are community mental health centers. And you don't have to be in a rural place for those two types of providers. And so the funding is limited. Now, that does not mean that faith-based organizations could not come together in a formation of a community coalition that includes these providers. So the hospitals, the clinics, for example, and be a partner in some coalition that may be applying for or wanting to have access to some of this money. One of the glaring areas that's not on the list of eligible facilities, which I think is important in our rural areas, is nursing homes. So, you know, nursing homes are fragile now. I mean, I was just in Ellenwood this last 2 days, and their nursing home closed a couple of years ago. So I think nursing homes are fragile. But my point in answer to the question about the nursing home inclusion is, again, they could be in a stakeholder coalition that could be part of the funding of a program or a set of programs that would help, at least indirectly, those nursing homes. In this case, you mentioned faith-based organizations, et cetera. I didn't you didn't mention, and because it wasn't on my CV, but when that you had, but I'm on the board of directors for the St. Francis Ministries out of Salina, and we do children and family services in all of Western Kansas. And so technically, we're not included as one of the providers here in terms of services, but we know that the welfare of our children is a really important factor in terms of overall health of a community. So I'm even thinking now about how St. Francis Ministries, for example, could be used in some of the programming as a coalition in the future.
Jacob in chat asked about if you could expand on how FQHCs may be included in this program. It sounded like you said FQHCs would not need to be rural located. It could be any FQHCs. Any more to add on how FQHCs could be included?
Well, they're on the list of eligible facilities, so presumably an application that may be directly funded in some form or fashion, FQHCs would be eligible in terms of the application to CMS. You're right. CMS does not require, the law does not require an FQHC to be located in a rural area. Now, the reason for that is that often it's difficult with FQHCs to know whether they're rural or urban, because you could have an urban FQHC that has sites in rural areas. So they may have two or three clinics, say around Wichita. I'm just talking theoretically now. I don't know this. They may have sites in two or three places, say in Kingman or Pratt. I know they don't, but let's say they did. Then you could easily wrap in that urban-based FQHC with those elements there.
And it, we seems to always come up in some of these conversations the challenge of what is rural and rural definitions. And I don't want to spend a lot of time digging into that today, but I think something I'm hearing that I'm curious to hear your thoughts. The the list of eligible facilities. So
Mhm.
who this funding could support, where it could end up going ultimately is pretty wide range. And I could imagine there could be some people sitting in a really small town in a small hospital saying, so this, you mentioned a lot of things that aren't us. And it feels like
Yeah.
we're
Yeah.
the ones on the shaky bridge. Is there any thoughts on how you've heard people thinking through prioritizing among all of these potential partners, or any concern about, will this funding, how can this funding be most meaningful and support those that have the greatest need? How do we think through this really complex resource allocation prioritization challenge?
Yeah. So you asked a terrific question, and it's one that I think if you're in a local hospital, so the question is, how do you organize something either at a state level, a regional level, or an individual hospital or community level? If you're in a hospital and you're not part of a larger system, or you're not part of a network, or you are a part of a network, but you have some needs in your rural facility, I would absolutely start putting together a fact sheet about your facility to submit to the governor's office once the guidance comes out in the middle of September. And once the guidance in terms of the state level grant writing development is taking place, and get your ask in to the folks that are going to be responsible for writing this grant. And I will say that we have a lot of good examples here. Um, this can include innovation that involves collaboration on integrated and electronic health records and enhancements. So maybe you need to do an upgrade to your electronic health record, and you use as your value proposition that you wanted to bring, say, more modern technology in terms of information systems to your rural community to help compete, to support to provide the foundation for your value-based care work, for example. So it's a win-win. You get better, HIT because that's a very expensive service that hospitals are required pretty much now to operate. Um, and I think that would be a way that you could do that directly. So that's an example. If you want to expand telehealth, for example, so maybe you have a telehealth that you would like to expand. I mean, there's all kinds of things that a hospital could look at that they can use funding for, that might help offset some of the losses down the road that they may get from the Medicaid program. So I definitely would, if I was in a hospital in Kansas and being an administrator, I would definitely be looking at my own application to the state for the funding, because that's where the action is on this funding opportunity.
So there's going to be decisions made by CMS in terms of funding distribution and for that 50% of funding, but
Right.
a lot of the decision making rests with the states, and it sounds like you're encouraging those that are doing this work to be proactive in sharing their challenges and opportunities, connecting with the state, connecting perhaps with other healthcare providers and entities in the region, to really, maybe help fill some of potential gaps of understanding of what the challenges and opportunities are.
Absolutely. I mean, I think that's a great way of summarizing it. I think there's just a lot of details that you could put forward that would be useful in them writing the application. So I don't think there's anything too small or too large. If you have a vision for what you think you needed a grant for. So I always say, and I say this in my PowerPoint presentation when I'm presenting to groups, think about something that you want to do that you couldn't do because you didn't have the funding or the working capital to be able to do the infrastructure to make it happen. So I use here as an example, many hospitals in 2016 participated in the Accountable Care Organization investment model. It's a Medicare-centered savings program. Way too much detail now, but the point that I'm making there is it takes millions of dollars of infrastructure to be able to stand up one of those. Um, and what CMS did was provided you the upfront funding through as a down payment on the savings that you're going to accrue later to be able to implement that program. And so if there's something that you're thinking you want to do, I use the example of the network over in up in North Dakota that used $4 million to develop their single signature authority. Maybe you want to do an innovative payment program that changes the dynamics of how facilities are paid. I mean, the sky's the limit. Now, those are pretty complicated, I will hasten to say. But I think that that's where I would be thinking right now is what can you use this money for that you wouldn't have been able to use, that you didn't have the money for, but had a dream that that's something you want to do down the road.
Yeah, and you've been shared lots of examples and ways to think about this. And another one of the phrases I hear you often say when talking about rural healthcare is the need to be innovative and creative. Innovative and creative. Those two words. And I one specific innovative and creative model and approach that I've heard brought up as potentially one of those dream big opportunities or lessons to learn from comes out of Pennsylvania. Can you share a little bit about the Pennsylvania rural health model? And maybe that's another example of being both innovative and creative and thoughtful about these big opportunities.
Yeah, so Pennsylvania got a CMMI, a Center for Medicare and Medicaid Innovation Grant for $25 million back in about 2018, and they implemented a five-year program to transfer all rural hospitals that participated into what we call a global budget, meaning that they were given a budget of money for a year's operation based on the previous 3 years' net revenues. And they were guaranteed that money. And so it stabilized their operations. Unfortunately, we had a pandemic right in the middle of that demonstration. And so I'm afraid the results of that were a little bit less helpful than what we would have liked. And then CMMI pulled the plug on it. So that's another lesson. I mean, some of these innovation programs, because they have useful lives that they end, then sometimes you can have this churning of innovation models. And so anyway, that program just ended, by the way, at the end of 20, it ended at the end of 2024. And so they're transitioning out of it now. But to answer your question, the one brilliant thing about the Pennsylvania model was it was an all-payer system. In other words, it was a line system across commercial insurance payers, Medicaid managed care organizations, Medicaid and Medicare. So all three of them participated in this global budget. So you didn't have a different payment system from Blue Cross and a different payment system from Aetna, and then a different payment system from Medicaid and Medicare. Even Medicare Advantage plans were included in the discussions. And so my point is that that was successful, but it had to end because CMMI pulled the plug on it. So that would be an example of a payment program that the state could consider moving into. It would be awfully complicated to set up, but we have the pattern in Pennsylvania. I mean, there is a prototype that they use to set that up.
Yeah, and it makes me think, flag that some of the ideas, some of the experiments, some of the innovations that come out of this may not last forever, but is there opportunity for us to be intentional and thoughtful about learning from all of this opportunity? I think you all at NRHA are in a good position. We hope that we can help play that role too and help us think thoughtfully about these opportunities and learn from the successes and from the challenges. Just flag a comment in chat about some of that same thinking about being creative and what are ways we can do transformational things when we never could have without this opportunity, but specific to a health department. So
Yeah.
thanks for that comment. I'm looking at our time. I'm looking at my mug. My mug's almost empty. I'm about out of coffee. We're about out of time. I we've covered a lot of ground, and I think there's still invite everyone that's on the call to look at the resource we shared that you all put together. Look at the resources that we're putting together at KHI to help all of us understand this opportunity and make the most of it. Um, I think about your career and your work, whether it was as a hospital administrator or in your role now, you've gone through some periods of some significant immense change, whether those were natural disasters or big policy shifts. You've mentioned some already. When you think about this period and all the shifts happening, all these challenges and opportunities that we've discussed, if we fast forward to the future, what do you hope comes out of this? What do you hope that we collectively, how we respond to this opportunity when we look back on it in 5, 10 years?
Well, it's a great question. And I do think that our rural communities are well positioned with energy, enthusiasm, and a hopeful attitude for the future. I mean, I go to hospital. As I mentioned, I was just at Ellenwood Hospital yesterday. I will say that there's a tremendous enthusiasm about the work that they do, passionate about the service that they're providing to their communities, and there's nothing you can do to to do away with that. So I guess I look forward to using this money to be able to orchestrate some tremendous impact that will be lasting beyond the 5 years that this grant program will be in place. And if we can even get, as a 10, 15, 20, 50%, success in terms of sustainability of these programming dollars past the next 5 years, I would be ecstatic. And I think that rural communities are laboratories of experimentation. And let me tell you, it's a lot easier to implement change in a rural hospital than it is a 1,000 or a 1,200 bed hospital in New York City. That is just no doubt. And so I think I'd love to see all hospitals, but our Kansas hospitals being leading the way in this innovation and becoming a real inspiration to hospitals and to communities all over the country.
I think that's great great hope and certainly an important note that we do have one of the greatest resources that we're not lacking is people that are committed to their communities and care about their communities. And with some good support, with some this thoughtful approach to these opportunities, we can have some really meaningful full impacts. And I really appreciate you taking the time to talk with us, to share your insights, your encouragement, and your ideas for how we can respond to some of these challenges, but also how it really is an opportunity to do some meaningful work and hopefully see some of that transformation. And just want to thank everyone for joining today. Want to remind everyone that you can come back and join us again in a month. We'll be here the last Wednesday of next month as well for our fourth session, and invite you to check out more of our work at KHI and the work that Brock and his team put together. And Brock, thanks again. I hope you enjoyed the conversation, enjoyed your community coffee, and a great conversation as much as I did.
Thank you. Great to be here. Appreciate the invitation.
Thanks, everyone.